dear friends, we'll discuss now on the medical management of Cushing syndrome. We know the Cushing syndrome is a multi-system or organ disorder. Particularly, it is due to hypercortisolemia. Next slide, please. And this characteristic phenotype of Cushing is there, involving the multi-system organ and next slide, please. Yeah. So we have the various particular clinical phenotype with Cushing syndrome, and it leads to multisystem morbidity and high mortality. Mortality is particularly mainly due to the cardiovascular system disorder, cardiovascular disease, because of the atherosclerosis and some cardiac disease or vascular disease can lead to higher mortality in case of Cushing syndrome. So we know this surgery is the first line treatment for the endogenous Cushing syndrome. Next slide, please. But still, there are certain discharge there that we cannot do surgery in particular patient, or we cannot repeat the surgery, or even after surgery, we see the persistent disease. So these are the various indications of the particularly medical therapy in Cushing syndrome. These are the persistent Cushing disease. This can occur up to 20 to 30% of the patients, or recurrent Cushing disease, which can be there even after 1 year. That can occur in 25% of the patient, or either as primary therapy or as bridging therapy. Once after the failure of the surgery, we are giving radiotherapy to the patients. But meanwhile, radiotherapy acts, it requires some time, particularly in many of the patients in 2 years or some 3 or 5 years. In one study, they have seen around in 2 years, around 46% of the patient got treated. But during this period, we require some bridging therapy. So the bridging therapy, as a bridging therapy, we can use the medical therapy. And somewhere when the non-feasibility or the refusal of the surgery, at that time also we can use the medical therapy. And acute complications of the severe hypercortisolism, at that time we cannot use the do the surgery. So at that time also we require medical therapy. And where somewhere the pre-treatment before the transsphenoidal surgery, even though transsphenoidal surgery can lead to some bleeding or like that. So during the tumoral bleeding or the operating site bleeding, so the visibility will be poor. So at that time we can just pre-treatment, we can treat the patients before for these various therapies, medical therapies, to decrease some bleeding instances. Next slide, please. So this would be our agenda of this presentation. So these are various medical therapy for Cushing syndrome, like Pituitary-directed therapy, like dopamine receptor agonist, somatostatin receptor ligands, heat shock protein 90 inhibitors, histone deacetylase inhibitors, this kinase inhibitors, and other therapy like temozolomide, which we are using for other neoplastic diseases also. Then come to the adrenal directed therapy. They usually inhibit the steroidogenesis. So these are ketoconazole, tevoketoconazole, this ketoconazole, and this oscillatorstate, etomitate, metadapone, mitoten. We all are aware of these all kind of medicines. Then come to the state inhibitor, this levanibimine. This is a new name, still under this phase 3 clinical trial. And then peripheral glucocorticoid receptor binders, or the antagonists like mifepristone or relacorilant. Next slide, please. So now these are the various site of action of these medicines, like PASIREOTIDE or LAR, this long-acting release PASIREOTIDE. They will act on the pituitary, and this CABERGOLINE also act on the pituitary, and this rescoventin, this also act on the pituitary. Metirapone, oscillatorstate, tevoketoconazole, these all act on the adrenal because they blocks the various enzymes of the steroidogenesis. Next slide, please. Now, this is the steroidogenesis pathway and drug acting on through this pathway. This pathway we are reading since our MBBS days, so I'm not going in detail in this pathway. Particularly what we see here, the various drug which act on the particular enzymes like mitoten, ketoconazole, they act on the 2022 desmolase, then 3-beta HSD. Here the mitoten again, it acts. Mitoten is the drug which act on the various pathways of various enzyme of this steroidogenic pathway, particularly in the most of the pathways. So it can lead to decrease in the cortisol, decrease in the aldosterone, decrease in other endogenic this androgens also. Next slide, please. So now the available drugs, if we see for the steroid synthesis inhibitors, the drugs which particularly act on the adrenal. So one is the ketoconazole. This is the very beautiful drug. We all are aware of this drugs. We are using this drug. It was developed as an antifungal drug. It was approved by the European Union, but not by the US FDA. It is used off-label for the Cushing syndrome. Mechanism of action is that it inhibits the 17 alpha hydroxylase, also beta 11 beta hydroxylase, 18 hydroxylase, also cholesterol sites and cleavage enzyme. As we know, the most of the drugs, this adrenal acting, which on the decreasing the steroidogenesis, which acts on the particularly most of the these adrenal enzymes, but they have the particular affinity for this some particular enzymes. So ketoconazole may affinity to the 17 hydroxylase as compared to other enzymes. It is recommended for the in the dose of around 400 to 1600 milligram per day for the blockage of this glucocorticoids synthesis. So it is updated usually with the 200 milligram per day every 7 to 28 days if tolerable. Next slide, please. So with the ketoconazole, we know in most of the trials, they have shown around 50 to 70% of the patient are found to have the normal urinary free cortisol levels. So again, the maintenance dose can be continued as above, or we know the adverse effect of the ketoconazole are mainly this hepatotoxicity. Then again, it can also lead to some gynecomastia or hypogonadism can also be there in this with the ketoconazole, and again this adrenal insufficiency can also be there. So block and replace regime can be used in the ketoconazole where the adrenal insufficiency is there. Next slide, please. As we know, where particularly we are using this ketoconazole on the adrenal, when we are using for the adrenal tumor or adrenal adenoma, at that time, this block and replacement therapy will require, because there is no ACTH drive to increase the glucocorticoid synthesis. It blocks the glucocorticoid pathway and synthesis will decrease, so secretion will be decreased. At that time, we require some this glucocorticoid maintenance dose. So as far as hepatotoxicity concerned, it is reported in 15% of the patients with ketoconazole, and in severe cases where the serious hepatotoxicity that is very rare, it is reported in 22 to 2.5% of the cases. In Fresco study, the increase in the liver enzyme less than 5 upper normal limit were reported in 13.5% of the cases, whereas more than upper limit was reported in 2.5% of the cases. So hepatotoxicity is there, but it is only severe toxicity is seen only in 2.5% of the patients. So again, it is not to be initiated when the liver enzyme are more than 2 times the upper limit of normal, or if they are increased during the treatment, if they are more than 3 times upper limits of normal, then we should reduce the dose or we should stop the drug at that time. Other adverse effects I have just already explained, like hypogonadism, gynecomastia, or QT prolongation can be there. Next slide, please. So we don't have the RCTs for the ketoconazole effect on this Cushing syndrome. So particularly 200 of the Cushing syndrome patients from the 14 centers in the France on the treatment of ketoconazole, they have treated. So majority had the clinical improvement like sign, diabetes, hypertension, and or the 49% of the patient experienced this normalization of the urinary free cortisol. Next slide, please. So in this meta-analysis, we see the ketoconazole is again found to be very efficacious. In 71% of the cases, the normalization of the urinary free cortisol was seen. Next slide, please. Now, oscillodorostate is the other this enzymatic inhibiting drugs which acts on particularly on the adrenal glands and decreases steroid synthesis. So it inhibits particularly have the affinity towards the 11 beta hydroxylase enzyme. It also inhibits the aldosterone synthesis enzyme. It is more potent and longer half-life is there, around 4 hours. So it was initially used as a drug of the hyperaldosteronism, but again it was it was approved in 2024, the Cushing syndrome by the US FDA. So dose around 10 to 80 milligram per day. Adverse effect again in most of these drugs causes the GI adverse effect and some causes hepatotoxicity. And we know again the adrenal enzymes are not synthesized; they are blocked. So the steroids like glucocorticoid, they are not synthesized. So again, the adrenal insufficiency can be there. So we should be cautious. We should be cautious when we are using such kind of drug, particularly in the adrenal adenoma. So again, mild hyponatremia or hyperaldosteronism can be there in the female. Next slide, please. Now, if we see the urinary free cortisol normalization, it can be seen in to 71% of the patients. So it is more efficacious than the ketoconazole. So linked programs were done for this evaluation. Linked one was a proof of concept study. It was used only in 12 patients for 10 weeks. Then link 2 was phase 2 trial. Then link 3 was the phase 3 trials. So here the dose was up titrated up to 60 milligram for over a period of 48 weeks in 137 patients. Next slide, please. So it have shown the efficacy of around 86% in normalizing the urinary free cortisol. Next slide, please. Next slide, please. So here, this is the phase 3 link. This trial, they have shown the it is normalization is in most of the patients. We can see the upper limit of the urinary free cortisol. Next slide, please. Again, we have compared in this trial with the placebo. So again, it is highly efficacious drug. Next slide, please. So now come to the levoketoconazole. So as you know, the ketoconazoles have the two enantiomers, dextroketoconazole and levoketoconazole. So in this two cis enantiomer, one is levoketoconazole. It is more efficacious, less adverse effect are there, less hepatotoxic is there. As far as hepatotoxicity is concerned, it is the dose is required 12 times more than the ketoconazole to be causing the hepatotoxicity. As far as efficacy is concerned, is more efficacious than the ketoconazole. And as far as dextroketoconazole is concerned, again, it is more efficacious than dextroketoconazole in case of this Cushing syndrome. It has shown that it is 2S and 4R enantiomer. It is stronger to inhibit the cholesterol side cleavage enzyme and 11 beta hydroxylase enzyme and 17 alpha hydroxylase enzyme. And it is applied for the FDA approval in 2020, but still approval is pending. Next slide, please. Adverse effects are similar with the ketoconazole and this levoketoconazole. But the severity is very less and frequency is also very less. So Sonic and this Logix program were done for the evaluation of the efficacy of this levoketoconazole in Cushing syndrome. So again, the Optics is another phase 3 trial which is still this recruiting the patients. In phase 3 trial, Logix still results are awaiting. In Sonic program, we have seen 94 patients with a 6 months of maintenance dose after the 2 to 21 weeks of dose titration up to 1200 milligram day. Next slide, please. So here we can see the this results of Sonic trial. Here the normalization we can achieve in the most of the patients. Next slide, please. So here in the previous graph, they have shown the different colors of the different dose, but they actually the dose titration was done in most of the patients. So now come to the metirapone. Metirapone is also a very beautiful molecule. It inhibits the particularly 11 beta hydroxylase and side chain cleavage enzyme, particularly the efficacy for the 11 beta hydroxylase enzyme. Although, as I have already explained, most of these drugs which are active on the estrogenic pathway, they act on most of the enzymes, but they have the particular affinity for the some particular enzyme. So rapid absorption onset of action is also rapid with this drug. It is USA FDA approval for the diagnostic agent for the Cushing syndrome, but not for the treatment. But the European Union has approved for the treatment. It is a preferred drug in the pregnancy. Again, it causes the hirsutism, hypogonadism also. So next slide, please. So we cannot use this drug particularly in the female. In the female patient where the hirsutism is common with the this metirapone, we can use the ketoconazole. But in the men particularly, we can use metirapone. Metirapone is better for the male patients, and female patients ketoconazole better. So in the many small studies, we have seen the effectiveness of this metirapone in Cushing syndrome. Here the normalization we can see up to 75% of the patients in various meta-analysis. Dose is around 750 milligram to 6,000 milligram. In 3 divided doses we can give. Most commonly reported side effect as usual, these are the GI side effect. Again, hypertension, hirsutism can be there, or mineralocorticoid precursor accumulation causes the hypertension. Next slide, please. Now the mitoten, it is a cytotoxic drug. It's also known as the adrenolytic drug. Particularly, it causes apoptosis process that is activated by destruction of the mitochondria, and this is the inhibitor of the cholesterol side chain cleavage enzyme, and also lesser extent 11 beta hydroxylase, 18 hydroxylase, 3 beta hydroxylase, hydroxyl steroid dehydrogenase enzyme. Onset of action is slow, and we know the half-life is long, so for the long period it remains inside the body. Dosing is again 1 gram per day, and we can titrate up to the 6 gram per day dose. Next slide, please. So the various side effects are again the GI side effect as usual with other drugs, and neurotoxicity is also there. So on neurotoxicity, sometimes we have to stop the drugs. Now in the largest series and 76 patients treated with the mitoten, 72% achieved the normalization of urinary-free cortisol. So more or less these all drugs causes the normalization of free cortisol in around 50 to 70% of the patients. Next slide, please. Now come to the etomidate. Etomidate is very frequently used drug for the anesthesia purpose, but for the Cushing syndrome, if we require the urgency to control the secretion, excretion of the this cortisol, then we require the etomidate. It is used in particularly ICU setup. It is strong 11-beta hydroxylase inhibitor. Mainstay of etomidate used in Cushing syndrome remains significant in severe hypercortisolemia. So in very emergency situation, if we require to control the hypercortisolemia, we require the etomidate dosing. Particularly, it is used in intravenous infusion in the dose of 0.1 milligram per kg per hour, or we can titrate the dose according 0.1 to 0.3 milligram per hour. Next slide, please. So particularly etomidate, we can use it for the monitoring purpose. We can use the serum cortisol level. But in the other drug, we can use only this urinary-free cortisol level, not the serum cortisol level, because where they like metirapone, they can also increase the CBG also increase. So at that time, we cannot use the serum cortisol level in that one. So now come to the glucocorticoid receptor-directed drugs. So mifeprostone, they block the glucocorticoid receptors. We cannot measure their action, their efficacy towards this by seeing some ACTH, some cortisol, but we can see only symptomatic improvement in the clinical features improvement of the Cushing syndrome. So mifeprostone is synthetic this steroid compound with considered anti-progesterogenic, anti-glucocortic protective these properties because of complementary inhibition of the receptors. It is approved by the US FDA for the management of Cushing syndrome with hyperglycemia. Dosing is 300 to 900 milligram once daily. Again, in 80% of the patients, subjects, we have seen such kind of many types of adverse reaction like GI reaction, headache, fatigue, hypokalemia, arthralgia, or menstrual irregularities can also be there. The big thing is that it causes endometrial thickening. Now, neither cortisol or nor ACTH can be used to see the efficacy of the drug. Next slide, please. So solely we are dependent on the clinical features of the Cushing syndrome. So this is a seismic trial, phase 3 trial in the USA, where we have seen the glucose level in the Cushing syndrome associated with hyperglycemic disease. Now, the blood pressure also in Cushing syndrome associated with hypertension among the 50 patients we have seen over the 24 weeks. 60% of the blood glucose was lowered by 25% and 38% of the blood pressure was lower. So 87% symptomatic improvement was seen with the mifepristone. So we can see only the clinical improvement with such kind of drugs. We cannot measure by some investigation or like that their efficacy. Next slide, please. Now come to the pituitary-directed drugs. So pituitary-directed drugs, the targets we know is the corticophobe adenoma. We know the pituitary, which is corticophobe adenoma, they are having a G protein coupled receptors. They include the somatostatin or dopamine receptor. Otherwise, they have the other receptors also like AVP or some other receptors. So we are using such kind of the drugs on those receptors. Still many drugs are pipeline which are pituitary-directed. We are not aware of many of the receptors which are there present on the pituitary adenoma. So in practice, we have the two class of drugs only, like the two agonist and the somatostatin receptor agonist. Next slide, please. So first come to the PASIREOTIDE. We know PASIREOTIDE is very efficacious drug in terms of the controlling the Cushing syndrome in Cushing disease. So it is a second generation somatostatin analog with high binding affinity for the somatostatin receptor 1, 2, 3, and 5. So as far as the difference is seen with the somatostatin or this PASIREOTIDE is that it binds lesser frequency with the ST2 receptors as compared to this octreotide and S1, S3, and this S5. For the S5 it is around 150 times more efficacious than the octreotide. So it is extensively evaluated in human clinical trials also, and it is approved from the FDA also, from the European Union also. So normalization of urinary-free cortisol after 6 months seen in 15% of the patients with 600 micrograms, 26% of the patients with 900 micrograms subcutaneous BID injection after 12 months of follow-up. So next slide, please. So now come to the, as we know this pasireotide, it is taken subcutaneously twice a day. So we know that we are fearing of injection. So because of this fearing of injection, we have developed this long-acting release pasireotide. This is given monthly injection, intramuscular injection, in dose of 10 to 40 or milligram IM monthly. So it is efficacy is better than pasireotide in various trials, and it causes tumor shrinkage also in 25% volume reduction in the tumor in various trials after the treatment of around 6 months. Next slide, please. Again, the adverse effect are the GI disturbances comprised of diarrhea, abdominal pain, decreased appetite, and the big thing is the hyperglycemia is caused by pasireotide or long-acting pasireotide also. The hyperglycemia from the long-acting pasireotide is quite lesser than the this pasireotide, short-acting pasireotide. So again, new onset of diabetes can also be there, worsening of the previous glucose impairment or can also be there. So the diabetes which is caused by the pasireotide cannot be treated with either with insulin or some DP4 inhibitor, or we can use some metformin also for that patient, and GLP-1 receptor analog can also be used. Cholelithiasis is caused by the long-acting release pasireotide, not by the short-acting pasireotide. Next slide, please. Now, again, this trial have the 12-month phase 3 clinical trial showing the efficacy of the pasireotide in Cushing syndrome. So, the various doses was used here. In the left side, we can see the mean decrease in the urinary free cortisol level, and other side we can see the particular in the fixed dose causes decrease in the urinary free cortisol level. Next slide, please. So here again the same trial say they have shown the different kind of doses in different patients, so how it is decreasing. So the same dose in the particular in some patients is decreasing the little bit this cortisol level, urinary free cortisol level. Somewhere the decrement is more in free cortisol level. So we cannot predict in which patients it will act more and which patient it will act lesser. Next slide, please. Come to the second agent. This CABERGOLINE is not a very new agent. We all are aware of this agent. This is a oral drug. It acts on the all 5 dopaminergic receptors. Somewhere it acts as the agonist, somewhere it acts as the antagonist also. The highest affinity towards the D2 receptor, where it acts as the agonist. It inhibits the ACTH, this release. As we know, this D2 receptors are present on the adrenal adenoma. So currently, it is suggested the second line off-label treatment for the Cushing disease, which is still not approved by the US FDA for the treatment of the Cushing syndrome. So again, the data suggests the same with the pasireotide, quite lesser than the pasireotide. Around 20 to 40% of the patients got this normalization of the UFC level. So with the CABERGOLINE, we have seen the escape phenomena also in 18 to 33% of the patient. Dose we know it is around 0.5 to 7 milligram. When we are using more dose, more than 3.5 milligram per week, then we should go for the cardiac screening also to see whether some valvular heart disease is there or not. Next slide, please. So in this first prospective single center open label clinical trial, we have seen the CABERGOLINE in the 20 patients with persistent disease after the pituitary surgery with this urinary free cortisol more than 1.5 fold than the upper limit. In this patient, they have given this CABERGOLINE. After 3 months of the period, the doses ranging from 1 to 7 milligram per week. The normalization was seen in the 7 patients, around 35% of the patients, and in 25% of the patients decrease in the additional 40% of the patients, with the total success rate around 75%. Next slide, please. So again, in this meta-analysis where they involve the 6 study, the first one, CABERGOLINE monotherapy induced urinary this cortisol normalization around 40% of the patients. Next slide, please. Now come to the temozolomide. Temozolomide is an alkylating this chemotherapeutic agent is used mainly for the neoplastic disease. It induces a cell apoptosis and tumor shrinkage and necrosis also. In if you see then one report where the 18 patients with Cushing disease, 8 with carcinoma and 10 with an aggressive adenoma, we have reported that the ACTH secretion decreased in 67% of the patients, and reduction in the tumor size was seen in 56% of the patients. So then second report, you see that temozolomide, it's affecting 11 patients with aggressive pituitary tumor. Again, they have shown the decrease in the hormone production in 63% of the patients, and tumor reduction in 55% of the patients. So it's very efficacious drugs if you see the other drugs compared with other drugs. So again, it should be considered in the therapeutic algorithm for the aggressive corticotrophic adenoma and carcinoma. Next slide, please. Next slide, please. So as efficacy wise, if you have seen, we know that temozolide we are using particularly when the tumor are refractory to the other these medications. Next slide, please.
Sir, 1 second. Start 1 second.
So the effectiveness is related to the co-expression of this expression of the ortho-6 methylguanine DLA methyltransferase. It's an enzyme which is able to repair the DNA damage. So it is used off-label in Cushing disease, particularly we use it in adrenal carcinoma or some refractory this pituitary adenoma or some aggressive pituitary adenoma. Dosing again 150 milligram per meter square once day, or we used to do this 1 day for every 5 days and for the total 28 cycles. It is acceptably well tolerated. The most common adverse effect, again, we know it is a neoplastic dust, so it can cause pancytopenia, nausea, vomiting, and fatigue up there. Next slide, please. So now, again, the drugs which are on the pipeline, the promising futuristic drugs which are acting on the adrenal gland. Next slide, please. So first come to the nevanibimab. So this is a novel selective potent inhibitor of the acyl coenzyme A. So again, is a synthesis inhibitor. So again, this steroidogenic synthesis inhibitor. Particularly, it was made for this anti-atherosclerotic agent, but now it is being evaluated in the Cushing syndrome, particularly ACC or adrenal this cortical adrenal hyperplasia also. So if it was used in dogs with ATR 101 cells, it decreases the adrenocortical steroid production, particularly ACTH stimulated this cortisol production in the dose of around 3 milligram per day or for 1 week, and followed by 30 milligram per kg per day by the 1 to 3 weeks. This suppression was around 90% of the cells we have seen. So still, it is under the phase of development. We are not using it; is not available. So it is used as released immediate 125 to 500 milligram doses. Next slide, please. So still in the phase. These drugs are also still in the phase of development. So again, relacorilant is a selective glucocorticoid receptor modulator that doesn't bind to the progesterone receptor. We know the mifepristone bind to the progesterone receptor also, so it doesn't bind to the progesterone receptor. Is being investigated for the dose of 250 milligram per day. It's found to be effective. So in phase 2, this multicentric, this open label clinical trial is published in July this year. In this study, we have seen that low dose of this relacorilant, it was administered for the 12 weeks. As 12 weeks, and the other side, the higher doses was used for the 16 weeks. So in this all subgroup, we have seen 5 out of 12 patients with the hypertension, 2 out of 13 patients and with the hyperglycemia, they achieved a good response. So we can see the response only by the clinical improvement. We cannot see the response by some investigations like cortisol measurement or the ACTH measurement like that. Again, adverse effects are like this back pain, headache, or peripheral edema. These are not so big adverse effect. Next slide, please. So now come to the this discoventin. This again other drug is a cyclin-dependent kinase inhibitor. We know the cyclin-dependent kinase are the drugs which cause a DNA repair at particularly somewhere the cell in the cell cycles we have seen. So inhibitor of the cyclin-dependent kinase, then again DNA will not be repaired in those cases. So again the cell will go in the apoptosis. So they act by the down regulation of this pituitary tumor transferring one gene and this Brahma related gene 1. So in the phase 2 clinical trial, still the phase 2 clinical trial, it has shown for the treatment of Cushing disease is underway. Next slide, please. So now the drugs acting on the pituitary, these are gefitinib, this carnitine and binimetinib, and this triptolide. These all are still in the phase of development, and we know that these drugs are particularly this epidermal growth factor receptor inhibitor or some EGFR tyrosine kinase inhibitor. They are used in the particular neoplastic diseases. Next slide, please. Now again, this veldoriotide or this danepsimycin, novoicin, these all drugs are still in the phase of development. One thing is the heat shock protein inhibitors. We know the heat shock protein also, if we see the glucocorticoid, they downregulates the ACTH synthesis, formation of the ACTH synthesis. So if in case of increased glucocorticoids, where the heat shock protein is there, that abolishes the effect of the cortisol on the particular pituitary gland. So these heat shock protein inhibitors, they decreases the heat shock protein this action, and by that the pro-immunocortin transcription and ACTH secretion is reduced by blockers of the heat shock protein. Then again, there is this trichostatin and this vernestat. These are again histone deacylate inhibitor. They again leads to hyperecylated nucleosome, increased expression of the tumor suppression gene. So these are particularly act on the aggressive this pituitary adenoma, or they are in the phase of clinical trial. Next slide, please. Now, retinoic acid has found to be ACTH lowering effect on the corticoid for this cell growth. We know the nuclear receptors are present on the corticoid for this adenoma. So they have used for that the retinoic acid. This particularly act on this is nuclear receptor ligand. So here two clinical studies are present for the testing the retinoic acid. The first is showing the total the 7 patients, the other one is the 5 patients. So they have seen 71% improvement or 71% achievement of the normalization of the urinary free cortisol level after 6 months of the therapy. Next slide, please. So other thing is that the retinoic acid actually it causes some other drugs like this cabergoline to act on the, it increases the ACTH receptor or D2 receptor on the this adenoma. For that the cabergoline can be act on the very well, or they enhance the efficacy of the cabergoline or some other drugs also. So if we are combining the two drugs for particularly this adenoma, we can use this retinoic acid with cabergoline or retinoic acid with some SST analog also. So this LD, this 1613, this specific high affinity neutralizing monoclonal antibody against the ACTH receptor. So they bind to ACTH receptor, this monoclonal antibody. So ACTH is not available. ACTH could not act on the particular adrenal gland to increase the synthesis and secretion of the cortisol. Still, they are in the phase of development. This neliveptan, again, this is the ABP-BR1B antagonist. So we know the ABP, this arginine vasopressin receptor are present in some adrenal adenoma. So again, acting the desmopressin will act on those receptors. Again, they will synthesize the ACTH, and that causes the increase in the glucocorticoids or increase in the symptoms of this Cushing syndrome. So these blockers of this ABP, the ABPR1B again decreases the this cycle where the ACTH act on the where the vasopressin will cause increase in the ACTH level. Next slide, please. Now this somatostatin dopamine chimeric ligand. So we know the somatostatin also act on this pituitary adenoma, and dopamine also act. So we have made some chimeric ligands which act on the both of the receptor. So we do not look at the two therapies. So still it is in the developmental phase. Next slide, please. So now come to the supportive treatment for the Cushing syndrome. We have to treat the hypertension, diabetes mellitus, osteoporosis. So hypertension, we can use the various drugs like angiotensin receptor blocker or angiotensin receptor angiotensin inhibitors, like that we should use in those in particularly hypertension patients. Diabetes mellitus is concerned, we can use the insulin or metformin or whatever the drugs are available. Most of the drugs we can use to control the diabetes mellitus and Cushing syndrome. Osteoporosis also, if in adult patients or when the age is less than 50 years or in premenopausal patients, we can use vitamin D or calcium supplements. But if the patient's age is more than 50 years, so postmenopausal female, we can use the bisphosphonates also. Infection, if we are seeing the cortisol levels are very high at that time, we should give the prophylaxis with the pneumocystis carni, particularly with cotrimoxazole, or infection should be judicially treated, otherwise patient may go in some sepsis. DVT prophylaxis should be started before surgery, and after surgery it should be continued. At least for 1 month it should be continued. Still some controversy is there whether to give for 1 month or 3 months, but at least 1 month it should be continued. Dyslipidemia should also be aggressively managed with the statin, and then dyslipidemia and other element we should take care of like that. Next slide, please. Thank you very much.